I'm going to talk today about the role of testosterone therapy in preventing severe illness from COVID-19. Let's start with a bit of a background. Right early on in the pandemic, it became apparent that men are getting sicker more than women with COVID. And this slide shows some data at a more global level from multiple countries. And the way it is arranged is that if you look at these purple squares, each of them is one female. So there are 10 over here, and all the rest of the bars, these stacked squares, are related to men. So the blue are all men. So for example, for every 10 female, we have 10 male cases as well. So men get infected as frequently as women. There is no difference. But in terms of hospitalizations and ICU admissions and death, you can see they are somewhere around 20 to 70% higher as compared to women. And this is not because they do not get vaccinated. It seems that the number of vaccinations in men is similar to those in women. Now, these data are not adjusted for chronic illnesses, and one of the explanation could be that men have more diabetes, more heart disease, etc., but it does not explain the whole story. Most people look at that and they assume that the main difference between men and women is that men have testosterone and they are getting sicker more, so testosterone must have something to do with that, and women have estrogen, and that probably is protective of that. So many investigators did think that early on in the pandemic. Is testosterone harmful? Is estrogen protective? And studies were actually initiated to inhibit testosterone signaling or to increase estrogen in men. And I'll just allude to 3 studies. We will not go into their details, but at the end of the presentation, I'll come back with the results showing what these studies showed. So one study was done in the VA hospital in veterans, and when any man came with COVID, they would give them an injection that got their testosterone levels down to close to 0. It's called androgen deprivation therapy. And then another group in Sweden, they gave them an androgen blocker, hoping that it would treat COVID-19. And then someone else tried to put estrogen patches on men, see if that will help. Now, there is some biological plausibility to this. The SARS-CoV virus, it binds to a receptor called ACE2, and that binding is facilitated by this protein called TMPRSS2, which happens to have an androgen receptor and an androgen responsive element in its promoter gene. So one may assume that perhaps androgen signaling would increase this protein and the binding of the SARS-CoV-2 virus. So we looked at this issue in a certain way. We wanted to see whether the expression of these proteins differ amongst the men with low or normal testosterone. We looked at 15 men with who were hypogonadal, they had low testosterone, and others who had normal testosterone. But of note, these are healthy men. These are not men who have COVID. And we did not find any difference in the expression of ACE2 in the blood cells on their blood samples. We could not detect TMPRSS2 in the mononuclear cells. So the next study we did in this area was to look at sex hormones, the testosterone, estrogen, etc., in men and women who were admitted to the hospitals with COVID during that acute stage. And I'll show one slide from that study. And there are 3 groups over here. Let's look at this group. So this group, the top curve, these are people who came with milder symptoms of COVID. They came to the emergency room. Many of them just went back home. Some of them were briefly admitted. But we took their blood samples for everyone who was admitted at baseline, which is at their presentation, and then at 3 days and 7 days and so on. And then the other 2 groups are those who got severe COVID, meaning they either went to ICU right away from the emergency room, or they ended up going to ICU or died due to COVID at some point during the hospitalization stay. And both these groups had really low testosterone levels to begin with. And during the acute illness phase, their levels had gone down to like 20 on a median, which is what we call as castrate levels, which is what we aim to achieve when we want to make somebody's testosterone close to 0. So it makes you wonder if somebody is trying to get a lower testosterone level to prevent against COVID, well, these men in acute illness are going to get those low levels anyway. However, none of this really tells us whether having a low testosterone prior to getting COVID is going to be beneficial or harmful, and neither will this tell us whether giving testosterone therapy during the acute illness is going to help out or not. So to answer that question, we conducted this study, association of male hypogonadism with risk of hospitalization from COVID-19. It was published a couple of months ago. And this was a retrospective cohort study. We did that in 2 large academic health centers in St. Louis. We reviewed the charts of men who had a history of COVID-19. Some of them got admitted, some of them had milder course and did not get admitted. And we selected only those men who had at least one testosterone level checked in the last few years. And these testosterone levels were done when they were healthy, did not have COVID. It was not a testosterone level while they were sick from COVID. And our goal was to compare the COVID-19 hospitalization rates among 3 groups of men. Eugonadal men, meaning those who have normal testosterone, or hypogonadal men, meaning those who had low testosterone but were never treated. And then the third group is those who were getting testosterone therapy. And we made sure that we did statistical adjustments for differences in the risk factors for COVID severity. You know, everyone knows that if you're older, you are going to have more chances of getting hospitalized from COVID or having a severe outcome. And similarly, obesity, immunosuppression, all other comorbidities, race, etc. And this is the total number of men in the study, 723 men. Out of these, 180 were on therapy, and the rest were not on therapy. 116 were low testosterone and 427 were hypogonadal. So let's see what their baseline characteristics were. So those who were hypogonadal, as expected, were older because, you know, aging causes lower testosterone. So they were older than the other groups. They did have more comorbidities such as diabetes and cardiovascular disease. The numbers in parentheses are all percentages. So 21% versus 11% in the hypogonadal and eugonadal group. And then 16% were immunosuppressed. But what really startled us was that 45% of these hypogonadal men ended up getting admitted if they had COVID, as compared to only 12% in the eugonadal group and 16% in the testosterone therapy group. Now, these are data before adjustment. So after all statistical adjustments for other risk factors, we made this graph, and it basically shows us that around the level of 200 nanogram per deciliter. I'll remind everyone again that the low limit is usually 300. So below 300, there is some risk, but below 200, it's really dramatically increased. And it doesn't seem to stop. In fact, there is this whole cluster of people over here who have levels close to 0. And actually, these happen to be men with prostate cancer who are on androgen deprivation therapy. There were 32 men, and 56% of them ended up getting admitted. So if somebody is thinking that androgen deprivation therapy will help men, our data does not support that. In fact, they are at the worst risk of getting a severe illness from COVID. So overall, what this basically means is that hypogonadal men are around twice more likely to get admitted from COVID, even after we have adjusted for everything else that we can think of would be a contributing factor towards COVID. And at the same time, those who are getting treated with testosterone do not have an increased risk of getting admitted from COVID. So we looked at this group of those who are getting testosterone therapy a bit more closely. So we got 180 men on testosterone therapy in this study. Overall hospitalization rate was 16%. Out of these, 136 men were adequately treated. their median testosterone level was right in the middle of the normal range, which is what we want it to be. And their hospitalization rate was low, 10%, very much the same as men with the normal testosterone who, eugonadal, never had problem. On the other hand, there was this group of 44 men who were not adequately treated, and they were on testosterone therapy, but really either they were not taking it or ran out or something like that, and their median testosterone level was like 150. So and their hospitalization rate was quite high, closer to the hypogonadal group. So it's really adequate testosterone therapy that helps. So I'm nearing the end of my presentation, and I wanted to share the results of the 3 studies that I had alluded to earlier. All 3 of them either showed negative results or they were abandoned. So in this one study where veterans were given 1 shot of androgen deprivation therapy to lower their testosterone levels as soon as they got admitted with COVID, that trial was stopped for futility. And they did not see any difference at all between the 2 groups. The other one, which was in Sweden, where they were blocking testosterone levels, it ended up causing a longer hospitalization period, and the trial was terminated early. And the estrogen patch study was also terminated after just a couple of patients. So I'll summarize by saying that low testosterone is not protective against COVID-19. On the contrary, it's a risk factor for COVID-19 severity. Hypogonadal men are twice more likely to be hospitalized after COVID as compared to eugonadal men, independent of other known risk factors. This increased risk was not observed among men receiving adequate testosterone therapy. And we need to think about screening and treating hypogonadal men appropriately as a strategy to prevent severe COVID outcomes among men. So thank you very much for your attention.